Morning, everyone. Mark Crowther, Chair of the department. We'll just give people a few minutes to join because it takes a few minutes for Zoom to fold everyone into the meeting, and then I'll introduce our speaker and we'll get going. Morning, everyone. We'll just take a minute to let Zoom fold people into the meeting and we'll get going in just a minute or so. Everyone will get going in just a second once the Zoom finishes incorporating people into the meeting. Okay, we'll get started. Good morning, Happy New Year, everyone. I'm Mark Crowther, Chair of the Department of Medicine. Welcome to the first of the Chair's Grand Rounds of 2023, which is hard to believe. We have an esteemed guest speaker this morning. I'll introduce her in just one second. Before that, just as a note, Dr. Azam, Dr. Verhofstadt, and I have decided to change how we deliver rounds starting now. So Chair's Grand Rounds will now officially occur every second month. That gives Khaled and Madeline a bit more time to do their rounds. And we're going to continue to do rounds electronically, and HHS and St. Joe's have decided to fold their rounds together so that we don't have competing rounds going on a Thursday morning at 8 o'clock in the morning. And we're also considering moving the time of rounds to noon starting in the fall because we know that this time interferes with sign over for those of us who are involved in clinical activity. So a whole bunch of changes coming to Grand Rounds, starting with this one this morning. I'm Mark Crowther, I'm the chair of the department. Our speaker this morning is Dr. Dawn Bowdish. Dawn is, I think, probably well known to everybody. She is a PhD scientist who does a lot of super important research in immunology, respiratory medicine, and has been a thought leader in an enormous number of different areas, most importantly and most recently answering a whole bunch of very important questions with respect to COVID-19. And Dawn recently became the executive director of the Firestone Institute here at St. Joe's. And I've asked her to present today to tell us a little bit more about the Firestone because it has undergone an enormous change from what I remember when I started here 30 years ago, which was that it was a clinically based institute. So Dawn, please go ahead.
Thank you so much for this opportunity. It's an honor and privilege to serve in this position and tell you a little bit about our work. I'll just start by acknowledging that St. Joe's, where the Firestone is housed, it sits on the traditional territories of the Anishinabe and Haudenosaunee Nation. And as part of my own personal movement towards truth and reconciliation, I acknowledge that colonialism has contributed to the health inequities in respiratory health and in infectious disease, which I'll talk about today. And if my slide will turn to the next one. There we go. 1 in 5 Canadians lives with chronic lung disease, and this number has changed in the past 40 years. In fact, COPD is the leading cause of unscheduled hospitalizations and emergency room visits. We also are struggling with a lung cancer epidemic. Lung cancer kills more people than prostate, breast, and colon cancer combined, but receives 5% of the directed research funds of those cancers. We also have asthma. Ontario has the highest asthma rates in Canada at 12%, but that pales in comparison to the rates of asthma in communities, which sit at over 40%. Shockingly, pneumonia and influenza have been on the top 10 causes of death for Canadians since the antibiotic era. And we can now add COVID-19 as one of the leading causes of death in Canada. And lastly, interstitial lung disease is a disease that's associated with the most early leaving from the workforce as people cannot continue to function at the level they had when they're living with interstitial lung disease, and is a major cost of unpaid caregiving, taking care of people with this. So collectively, the field of respirology is one that is in dire need and yet is very, very underfunded compared to other disciplines. The Firestone Institute for Respiratory Health aims to improve the health of people living with chronic lung disease, and we are a unique mix of translational research, education, and of course, the most exemplary clinical care. This is our leadership team. Our team includes people who represent clinical service, education, and research, and we work together to help lead the strategic directions of Firestone Institute for Respiratory Health. We have a very fascinating history, and I'd encourage, if any of you know Malcolm Sears, he's written a memoir of his time from the initiation of the Firestone, which includes a wonderful story about him meeting Sophia Loren and the official opening. The Institute started in collaboration primarily with, in the context of allergy and respirology, but really grew and expanded to include a number of basic scientists, PhD scientists, colleagues in thoracic surgery, et cetera. And I think it's this special mix of the PhD scientists who, when I think of us as a collective, you know, this is what we do. We drink coffee, we read manuscripts, and we know things, including knowing how to do things and do these really deep technical investigations. And that partnership with our clinical colleagues who are on the front lines, who are seeing and experiencing the patient perspective and are implementing this research into clinical care, this is what makes the Firestone so special. Indeed, what we do is we calculate where our trainees come from and where they end up going. And we're proud to say that every continent has a Firestone trained researcher and clinician on it, that we've had dozens leave. And in fact, many of our former trainees have populated the Canadian respirology scene. You can't shake a stick without hitting a Firestone trainee in the respirology field. And all of us have a different vision of how we're going to bring our work into cause impact. We start from the basic. We have, you know, the PhD scientists and the people who are really driven by curiosity-driven scientists studying signaling pathways and immune mechanisms. We have people who want to really understand some of those clinical manifestations of disease and move those to understanding why they happen and really build that translational science base. We have people like Jay Hirota and Mark Larche who've done an incredible job of bringing these findings and research into the commercialization sphere because they acknowledge that this is one of the pathways to improve the care for people. I'll speak in detail about our work with clinical trials because this has been an extremely important way for us to change the dial on how clinical care is administered, and frankly is the lifeblood of our research institute. There's also a number of our members who are changing practice locally. I'm going to share with you today some of the innovative programs to improve care locally and to slow disease progression, and the incredible quantitative science they've done to prove that these work, and then pass on this information to our team who's interested in changing practice both nationally and internationally. Many of our members are involved in guideline development and are in professional societies where they can help bring these recommendations to practice. And one of the things I'm hoping to bring to the Firestone in my term as executive director is moving from policy to advocacy. One of the things that this pandemic has taught me is that we need more people with deep insight and lived experience to be speaking to policymakers and to be advocating for change. Otherwise, we'll always struggle with moving things from our academic medical center into the community in general. And there's a lot of equity work that needs to be done in the context of respiratory medicine. And I think the Firestone researchers are the team to do that. So for those of you who don't know, we are part of the St. Joe's ecosystem. We work in the St. Joe's site primarily, although many of us have arms off-site. We are very proud of the support we've got and the community that exists for us at the St. Joe's and the St. Joe's family. So I'm going to tell you a series of stories today. And the first story I'm going to tell you is about our work in interstitial lung disease. Interstitial lung disease is understudied compared to the burden of economic costs, but we happen to be home to the largest clinic and research program in disease likely in the world. On the left, what you're seeing is Martin Kolb working with a number of patients who are doing some fundraising activity. And on the right, what you're seeing is the Firestone Clinic where the patients are seen. There are about 2,000 patients who are seen and followed annually. And I just recently had the honor and privilege of sitting in one of the clinics and getting to see firsthand how the patients adore the respirologists for taking that time to do this really deep investigative investigation of them. And this has really led to a number of high impact publications and led to Martin Kolb, Jack Galdi, Jerry Cox, Nathan Hambley being established researchers in this field. And one of the things that we have is an incredible support team to support the research endeavors. So I'm going to introduce you a little bit more to Sarah Goodwin, who's on the right there. But one of the things that we've always believed in is that patients deserve to be involved in the research process. And I'm going to tell you a parenthetical story here, so open parentheses. Over the course of many years, a lot of our participants who sign up for various research studies sign consent to contact to be contacted for other research studies. And so my own research is in aging, and very often either patients at the Firestone or people who've signed up for other research studies or their healthy controls end up coming into my studies as well. And I had this experience many times over where one of our clinicians' patients ends up being in one of my aging studies. And I always like to meet our research participants and hear about their stories. And one of the things that they always speak so glowingly about is how meaningful it is to be involved in research for them. Many of our patients have a chronic disease that will eventually be terminal, and they're very much aware of that. And yet there are, as I will discuss in a few minutes, socioeconomic challenges where they're not the kind of people who can necessarily give $1 million to research. So what they give is their time and their selves. And I'm always amazed by how grateful they are for the opportunity to be involved in research and how grateful they are to be able to give back to patients in the future. And so it's no surprise to me that our clinician scientists, researchers, and staff who support the research facility have been nominated over 100 times for what's called the St. Joe's Miracle Worker Award. The St. Joe's Miracle Worker is a way for a patient to write a story, to share an experience and get nominated for one of these awards. And not only do our clinicians get these awards, but also our research staff and researchers. And that sort of meaningful relationship between research and the patient journey is one that I hope to always honor and to share with you. Okay, in parentheses. The other thing that we believe in very strongly is the importance of collecting patient data for national and international registries. So we have the largest registry called CarePF for pulmonary fibrosis in the world. And this registry has really bloomed to include patient data, patient metadata, in some cases biospecimens, and has led to collaborations around the world. There's been many, many important studies that come from this sort of work, including a really fascinating one that's in JAMA last month, discussing the role of air pollution in the progression of chronic pulmonary fibrosis. So this sort of registry work allows us to ask retrospective questions about the patient experience and to understand environmental and other factors that contribute to disease progression. Now, the second story I'm going to tell you is one that the Firestone is extremely proud of and speaks to both our august history and is future forward looking. One of our members, Freddie Hargreave, was a visionary in the field of understanding airway hyperresponsiveness and severe asthma. And he, along with a young Paul O'Byrne and Prem Nair, have developed tools and technologies to measure the kind of cells that are found in the lungs in the context of asthma. And so by simply measuring the types of cells that are found in the sputum and deciding and looking at what kind of cells are found in the sputum, they're able to make a decision tree around treatment. And so the beautiful simplicity of this method has led to a profound change in patient responses. If a patient's characterized by having a lot of eosinophils, then one would move in one direction. If a patient's characterized by having a lot of neutrophils, one would presume that there's some role in infection. And by understanding and not grouping all patients having an exacerbation or all patients having asthma into one group and using this endophenotyping procedure, outcomes can be improved, antibiotics can be spared, and importantly, disease progression can be slowed. This has led to the field of respirology taking an approach to clinical trials that's almost more like what happens in cancer. So in almost every cancer type, one would not one does genotyping, one directs the treatment to the genotype of interest. And yet in airway disease, people would group people by disease, mild, moderate, or severe asthma. And as a consequence, sometimes treatments were found to be ineffective. Using these sputum cytology guidelines to figure out if a patient's characterized by an eosinophilic versus a neutrophilic assay neutrophilic versus eosinophilic cells means that you can tailor treatment, for example, the anti-IL-5 to the patient who would believe to be benefit most. And by doing this, we have a number of publications in the New England Journal and elsewhere showing that exacerbations can be prevented and treatment can be improved. This deep knowledge of how to get the right patient into the right trial has been used over and over again with great success by the Firestone clinician scientists. As an example, we have had a strong research program understanding the mechanisms of asthma. These have included things like understanding cytokines like TSLP1 or IL-23 or other cytokines that perhaps mean nothing to the non-immunologists, understanding the role of the smooth muscle in the context of asthma, that things like thermal bronchioplasty can be used. This deep knowledge of the patient experience that comes in part from our basic research team has allowed clinical trials to be used in a really directed way and allowed Firestone clinicians to trial many different interventions. And I just want to, go back to that last slide there. And this has been, I'm using the example of asthma here, but I do want to be clear that in fact, we also have had a deep base of knowledge in interventions for COPD and interstitial lung disease as well. One of the big things that I've been so pleased that our executive team has agreed to invest in is the infrastructure to support these trials. We have an incredible team led by Sarah Goodwin, a long-time trial coordinator, patient favorite, and incredible asset to our team. We also recently hired Anna Shuvalov, a research nurse who's been leading some of these trials. We have a database manager and a research coordinator. And the model that we've used in the Firestone is that this deep bench of technical skills and administrative skills should be accessible to everyone. And so what we do is we support our junior scientists or clinician scientists who need access to this experience by subsidizing them and by using a cost recovery model for our senior investigators. And this allows an easy in to people who might not have the infrastructure within their own research group to do this work. It seems to be working. We have, as of last week, I believe we have 17 trials in interstitial lung disease with over 300 patients ongoing at the moment. And we've had a heady mix of both investigator-initiated and academic industrial contracts that have been that we've been able to get because we've got this deep base of personnel and skills. It also is important to me that we support our junior clinician scientists. I think it's been an extremely difficult time for them to start a research program, and by having people with strong expertise that they can access without having to train, this is one of our major ways that we support them. So going back to this beautiful, elegant, simple way of patient endophenotyping and acknowledging that asthma or severe asthma is caused by many different etiologies or has many different pathophysiologies, our junior researchers have really moved the dial in understanding and taking this to the next step. A source of endless frustration is that we have sputum cytology that works so very well, and yet it's been challenging to get other medical centers, including academic medical centers, to implement this. So Dr. Manali Mukherjee, who is trained in the context of the sputum laboratory, acknowledged that it's a challenging program to run. There's one full-time medical laboratory technologist, there's a full-time master's student who's involved in research, and there's other ancillary support that's required to do this kind of sputum cytology. So one of her major research programs is to try to bring it to the masses. I call it the democratization of sputum cytology. She's developing protocols to take sputum that can be sort of induced without too much difficulty, and basically turning it into a histology program where a clinician collect the sputum, hand it off to a technologist. They could formalin fix it, slice it, and use histology, because most hospitals would have access to that as a tool. And so this democratization is one of the ways that she hopes to make an impact and bring this into more general practice. Because despite the fact we have dozens and dozens and dozens of examples, multiple publications showing it improves patient outcomes, uptake seems to be unique to our institute. We have Dr. Sarah Svenningsson and Carmen Venegas Garrido, who are interested in understanding the different pathophysiological mechanisms of asthma using lung imaging. So Sarah is one of our junior researchers who's been funded through the CFI program to create the Translational Pulmonary Imaging Research Laboratory. This is her beside one of her big pieces of equipment, which I will struggle to explain the technical aspects of, but I can certainly explain the basic mechanisms of. She acknowledged that most of the imaging that's done clinically, such as a CT scan, can look at sort of the structural aspects of, not the functional aspects of the lung. The actual ability of the lung to transfer oxygen and move carbon dioxide out is not something that's captured by many clinical scans. And so what she's done by using this technology is found ways in which she can measure some of these functional changes, and it finds that there are differences in patient phenotypes. And Carmen are looking at a number of different lung conditions, but one of Sarah's major contributions in the last few years in the COVID effort is to help explain this really frustrating and disheartening clinical observation where many patients who suffer from post-COVID condition have this feeling of breathlessness or this post-exercise exertional fatigue, and yet they're told their lungs are completely normal by all normal lung scans. What Sarah's done here is she's compared CT scans with her xenon MRI imaging, and the arrows point to areas where the lung is not being properly perfused, where that oxygen carbon dioxide exchange is not correct. And she was one of the early people to demonstrate that these functional abnormalities occur. They're real. They're not a figment of the patient's imagination. However, they are not going to be caught by more conventional lung imaging. And now she can use this technology to help understand other challenges in the context of chronic lung disease. So what I've tried to share with you now is our both basic science and clinical understanding that many chronic lung disease have very different etiologies and pathophysiologies, and treatment needs to be tailored to those pathophysiologies in order for it to be successful. And one of our major strategic directions in 2022 is to bring this into the genomic era by creating the Michael G. DeGroot Center for Chronic Lung Disease, which we can do due to a very generous donation from the Michael DeGroot Center or the Michael DeGroot Board. Our vision is that by combining the scientific insight about how these diseases are or originate, as well as retrospective and prospective biospecimens with patient metadata and a deep analytics base, we'll be able to discover, prevent exacerbations and discover the causes of and develop new treatments for chronic lung disease. And again, our strategy, which has been one that's worked so well for us, is to invest in people. So one of the people we've invested in recently is a bioinformaticist named Dr. Anna Dvorkin. We have Anmar, who helps with our patient metadatabases, and Victoria, my second in command, who helps with both financial management and running the center. effectively, what the center is not so much, many centers in a university setting are groups of people, but this is really a group of tools and technologies with whom anyone can enter and anyone can share and work with us. And in fact, many of the things I'm going to show you today are applicable to any disease. And so we hope that our expertise will help others build similar resources. One of the things that we build are what are called tissue. So by using samples of lung, or in some contexts, the immune system, we can create these tissue microarrays, and I'll show you an example in a second, that can allow us to both discover biomarkers of disease severity, of disease type, and also to measure treatment responses, to try to understand the heterogeneity in which people respond to treatments. Another incredibly underused resource are patient data themselves. We don't yet truly know what factors are associated with disease progression, but by creating large databases, we can search for these. And I'll show you an example of how we're doing that. Endophenotyping is becoming more and more complex. Immunologists are accused of being lumpers or splitters. So lumpers want to group all cells together. All eosinophils go into a group, all macrophages go into a group, all neutrophils go into a group. And splitters want to further characterize different subsets of macrophages, neutrophils, eosinophils, etc. And as it turns out, some of the splitting looks like it's going to be extremely important in the context of chronic lung disease, because some of those patient phenotypes are even better defined once we get down to those specific transcriptional profiles or functional profiles of those immune cells. So by banking cells and having this deep base of analytics activity, we'll be able to look at transcriptomics and proteomics and high content flow cytometry to understand differences in patient responses. So this is an example of a tissue microarray. And this is all on a microscope slide. So imagine a small little microscope slide. On that slide, we take a little core of lung in this case, and you can see that there is control. So people are healthy with no lung disease, people who have IPF, sarcoidosis, COVID-19, et cetera, et cetera. And each of those cores is a different individual with that particular condition. Now, using these slides with these tissue microarrays or these cores, you can look to say, is protein X expressed in this? Is structural feature Y found in one disease or another? And do these sort of comparative studies. You can also design a tissue microarray instead of looking across diseases like we're doing in this example, to pick samples from within a disease and maybe break down patients into people who responded to treatment or didn't respond to treatment. And again, look for biomarkers that assist with that. The search for biomarkers is something that's incredibly important because many of the treatments for chronic lung disease are insanely expensive and difficult, and often don't provide any patient benefit. So if we could identify people who would benefit from the treatment, not only would that be cost saving, but would allow clinicians to redirect patients who wouldn't benefit into other treatments. This has been, these tissue microarrays have been incredibly sought after resource from our academic industrial collaborators as well, who want to be able to understand how their treatments work. This graph is one of the investments we made with our bioinformaticists. What we needed was a way to look at patient data quickly and understand what samples we have and what we could do with this data. So this mock-up of a patient has been with us, as you see on the bottom, for quite some time. You can see that we have measures of their lung function in the green, blue, and teal lines, and we have all their patient visits. We have on the bottom there, we have the list of drugs that they're on. And on the top, we have, whether they progressed or when they were diagnosed, et cetera, et cetera. What we also have here is we have in the sort of vertical bars is we have an indicator of when we had collected a biospecimen from them. So for example, the first biospecimen we ever got from this individual was plasma. We have some RNA sequence, some transcriptomics in the yellow bars there. We have some peripheral blood mononuclear cells there that are banked. And so you can imagine the strength of having both this biospecimen repository as well as all this patient data Because if you wanted to say, what was the, I'm looking for X number of patients who are on treatment Y and had 3 exacerbations a year, you could look for that, and then you could use these biospecimens to probe causes and the consequences of this for the individual. So one of our major activities now is consolidating all our various patient metadata bases to create easy visuals that researchers can use to gather biospecimens and ask important research questions. All right, so that is one of our major strategic directions, but another one is to tackle one of the most challenging aspects of chronic lung disease, which is the presence of exacerbation. Chronic lung disease is characterized by these generally infective exacerbations and acceleration of disease progression. So this is an example of people living with COPD. And you can see that this survival curve is pretty grim. And this is after their first severe exacerbation. And in fact, once you're hospitalized for your first exacerbation, you're more likely to have a second one. And that accelerates the process further. And then a third one, and that accelerates the process further. In truth, if we could prevent these exacerbations, we could probably turn many of these chronic lung diseases into things you die of, or die with, not die of. And you would think that in the era we are, where we have vaccines and antibiotics, we'd be better suited to prevent these, and yet they're not. And they're the major clinical problem, the major reason for those unscheduled hospital visits. And one of the things that most people don't understand is that having a serious respiratory infection isn't just a problem in the here and now. It profoundly affects the aging trajectory. There's been epidemiological data for decades saying that a serious infection like pneumonia or influenza accelerates the risk of dementia, cognitive decline. There are strong associations with serious respiratory infections and heart attacks, strokes, and other cardiovascular events. And furthermore, having pneumonia or influenza in mid to late life accelerates frailty, disability, and loss of independence. So preventing infectious disease doesn't just stop hospital visits, it profoundly influences the aging trajectory. The Firestone takes a two-pronged approach to this, fixing the here and now, and then looking forward to the future. We have a COPD team who has developed a really comprehensive care program. Patients who come for an exacerbation are treated by the team. They have this an extensive virology panel done, much more extensive than many other centers. They're discharged from the hospital and they enter into the integrated comprehensive care program where they're seen in the community, and they have access to things like rehabilitation and other programs, patient education programs to help them manage and prevent this. And this team has published on the effectiveness of this sort of integrated process in preventing hospital admissions. So this combination of care, education, and treatment really helps slow down this progression in the here and now. We've also recently submitted a $4 million grant trying to understand and make this future, improve this in the future. So by working with a number of our infectious disease colleagues, and as well as people like Mike Surrett, one of the things that we hope to understand is what are the causative agents of some of these infective exacerbations. It's shocking to know that most people have a very limited panel of testing when a patient comes in. Maybe they look for influenza, maybe they look for COVID, but they probably don't care very much about your everyday pathogens, your rhinoviruses, your adenoviruses. But the science says that many people with chronic lung disease do have an exacerbation because they encounter something new and exotic. But there are changes to the immune system that mean that they respond inappropriately even to very common pathogens. And in some cases, it may not be a new virus per se, but one that they've been living with for a while. And there's a trigger that leads to changes in their airway microbes that lead to this inflammatory event. So by collecting these samples, banking them, and allowing us to look for both the viruses one would suspect and many of the things one wouldn't suspect, what we hope to create is a bank of samples where we can move these into responds profoundly differently than the young immune response to many of these pathogens. So we can use mouse models, and especially our aging mouse models, to understand how these viruses interact with the aging immune system. We can also use those banked biospecimens to study host microbiome or host microbe interactions in a way that's sort of a unique asset of our team. One thing that was a huge eye-opener to me in the beginning of the pandemic, and this is a bit of an opening of a parenthetical story again, was we, at the beginning of the pandemic, we didn't really understand how antibody testing to see if somebody had been infected would work. So with these researchers here, my Firestone colleagues, we ran around and we recruited a whole bunch of people who had pre-pandemic serum samples. And then we would follow them over the pandemic and see how antibodies to COVID would develop. One of the things I was extremely shocked to find is that many of our patients living with chronic lung disease actually had sort of COVID antibodies pre-pandemic. What they actually have are antibodies to seasonal coronaviruses at much higher levels than the general public. And this opens a fascinating question. Are they more susceptible to seasonal coronaviruses and no one ever knew this because no one ever tested for it? Or now that we know that the coronaviruses have these effects on the lung ultrastructure, could it be that this seasonal coronaviruses contribute to some of this disease development? And closing parentheses, understanding what viruses lead to what degree of progression will help with our understanding of both the disease etiology, but also help us develop new diagnostic tools. And I think preventing exacerbations is a targetable challenge that we are uniquely positioned to answer. Now, of course, I've shared with you some data about the role of serious respiratory infections in the development of long-term health issues, and COVID has really brought this to the forefront. COVID is associated with, as I shared with you, decreased lung function, at least in some people. By some accounts, a 20 times increase in myocardial events post-COVID, and certainly we are seeing frailty and disability. And post-viral syndromes like COVID have actually been existent forever. They just have not been to the forefront. I love this Edvard Munch self-portrait where he's painting himself as he's recovered from the 1918-1919 influenza pandemic. And by all his accounts of his diary, he was suffering from a post-viral syndrome not dissimilar to long COVID. On the right hand here, you're looking at data from Marla Beauchamp and team, who's been following the trajectory of people who were hospitalized for COVID, and found that indeed, for many people, 12 months later, they're still suffering with quality of life limiting challenges, including fatigue, headaches, joint pain, et cetera, et cetera. The sheer number of COVID infections we are experiencing mean that these challenges and health implications are being felt now and will be felt for decades to come. And Firestone researchers rose to the challenge. Rebecca Amer and Zane Chagla had a long history of working together in infectious disease respirology clinics, especially around TB, and quickly mobilized to create a long COVID clinic, of which many of our researchers now contribute to. Many of our PIs, Marla Beauchamp, Mylan Natia Regahaven, developed the COREG, or Coronavirus Registry, to help follow and study some of these people to help understand what their health outcomes would look like. And in collaboration, our basic scientists, Manali, Sarah, have made some pretty remarkable discoveries about some of the immunological changes that happen in people post-COVID. And again, this intersection of clinical observation and basic science has led to a pretty phenomenal discovery that Manali is doing the public relations rounds with as the paper has come out today. What Manali and Sarah and team found is that many of these long-term health changes, and I'm showing you here the dyspnea and fatigue, are not as strongly associated with many of the features that one might look at clinically, but are strongly associated with the presence of autoantibodies. The damage that seems to occur in a COVID infection seems to unleash a number of autoantibodies being formed. And this nascent autoimmunity seems to be a stronger correlate with many of these long-term health issues than anything else. This provides us with two interesting workable hypotheses. One is that we need to be thinking about immune-mediated treatments in order to sort of slow this progression. And two, we can reasonably expect that autoimmunity may be on the increase as part of the post-COVID condition. So as I sort of move towards the finishing up, I want to talk to you about another really important strategic direction. My personal research interest has always been in the aging immune system and how that impacts respiratory infection and chronic lung disease. We know that lung health is good health for older adults. This is a study led by Mylin Duong, and she looks at lung capacity, just a basic measure of lung health, and compares people who have great lungs versus people who have impaired lungs. And she finds an epidemiological association with death of all causes based on lung function. This observation has been repeated across populations over the world. Good lungs seem to be linked to good health. And when we look at one of the factors associated with chronic lung disease, there are many. There are non-modifiable factors. Obviously, smoking is associated with that. Air pollution is a major issue. Previous history of infection. There's occupational hazards. There are things we can't change. Our sex and ethnicity. We also, having had one chronic lung disease, is a risk factor for developing other. But by far and wide, age is in general the strongest risk factor for that. And aging is something that is not even. And we know that one of the differences in how healthy your lungs are or how healthy your immune system is where you live. Statistics Canada's best predictor of how long you live is the postal code you live in. Second best is the postal code your mother was pregnant in. We know that lung function has major socioeconomic disparities, partially because your ability to control those non-modifiable or those modifiable risk factors, having a safe working environment, living in a safe place, having high air quality is associated with socioeconomics. But fascinating, and one of the things you might not be aware is that there's this intersection between lung aging and immune aging, and it seems to be bidirectional. Socioeconomic status is directly linked to the rate of immune aging. And what seems to happen is the lungs and the immune system have this really intimate relationship where the epidemiological studies showing that if you have poor lungs, your immune system ages faster. And if you have a prematurely aging immune system, your lung function decreases faster. So we know that lung health is associated with good health and longevity. Also, COPD is considered to be a disease of premature aging. When we take the blood of people who have COPD, we see that they look on average about 10 years older from immune status. And one of the reasons that COPD is associated with this rapid progression of frailty and more comorbidities is believed to be because of this accelerated immune aging. Pulmonary fibrosis is a different story and a really fascinating one. If you take human lungs and you strip them of all the cells, you decellularize them, as they call it. You take all the cells off so that you've only got the collagen and the fibrogen and all those structural aspects of the lung, and then you reseed them with lung tissue from a healthy young person. You actually recapitulate pulmonary fibrosis. You get the scarring of the lungs. And that's because the aging of those connective fibers, that aging of the ultrastructure of the lungs actually sends messages, inappropriate messages that lead to lung scarring. I love those studies. And Jay Hirota, in collaboration with Jose Moran Mirabel, have just put in a number of great grants, and including a CFI grant, to really understand how that the structural aging of the lung dictates the rest of the lung function. And like I said, there's this bidirectional relationship between lung function and chronic inflammation. This is one of my favorite studies that I always share, that says that if you are higher than age average for 3 common measures of chronic inflammation, L6, CNF, CRP, your mortality rate is much, much lower, or much, much faster than if you were lower than all 3. And this is because immune function is linked to all-cause mortality with age. You need a healthy immune system to age well, and you need healthy lungs to age well. And like I said, one of the things that is so fascinating is you improve one and you improve the other. One of the things that the Americans have invested very heavily in is understanding how lung aging influences the aging trajectory by using senolytic drugs. So these are drugs that target those prematurely aged cells and kill them, and you seem to improve lung function and inflammation. Really fascinating. I'm going to just skip this so we have some time for questions, but I just wanted to share with you that one of the things that we do in my lab is we age old mice, and we age mice that are protected from this inflammation that occurs with age. And we see that so many aspects of their physiology are protected. They don't lose their muscle mass with age, their lungs are pristine, and they even do better in the context of a bacterial infection. I'll just skip this for time because I want to make sure I have some time for questions. But one of the things that I was excited to bring to the Firestone was my lab has one of Canada's only aging mouse colonies, where we are able to measure things like metabolism and frailty and changes in the immune system, the microbiome. We have the world's only germ-free old mice to understand how the aging host influences susceptibility to infection. We're able to recapitulate the development of frailty in mice and understand how that impacts infection. And then one of the things that I'm also really excited about is we're able to infect our older mice and then watch as they develop cognitive decline and many other comorbidities and test interventions. So one of the last things I wanted to share with you is, like I said earlier, the COVID pandemic has taught me that we need to have more voices from McMaster, from St. Joe's, from the Firestone in the public domain. We need more policymakers to know that they can call upon us and our expertise, and we need to be guiding the agenda for lung health. I am a strong believer in advocacy. It is shocking to me that we have vaccine preventable diseases in our leading cause of death: influenza, pneumonia, COVID-19. And not only that, we have vaccine preventable cognitive decline, cardiac issues, and frailty disability. One of the things that I think we need to advocate for is using the tools we have better. Canada has set a goal of 80% vaccination rates for influenza. And even in older adults, we never get past 70%. That 80% should include people with chronic lung disease who are younger or other chronic health conditions. We rarely get to 40% with that. And as a consequence, we are not doing everything we can to prevent those infections and to prevent those vaccine preventable long-term health issues. I'd like to tell you a story about my work in COVID-19 to illustrate this. My colleague Andrew Costa and I run Canada's largest study on COVID vaccinations and infections in older adults, especially those in retirement homes and long-term care. This has been a long-standing research interest for both of us. And when the COVID pandemic hit, those first 2 waves were absolutely devastating in the long-term care, and both of us felt this viscerally. 0.05% of Canadian or Ontarians live in long-term care. But if you look at April 20 and May 2020 on this graph, you'll see that 0.05% of the people had the same amount of deaths as the rest of the 99.5% of the population. Canada led the world in deaths due to COVID in long-term care and retirement homes and assisted living. We're number one. We led and this has been a long-standing issue. In fact, we actually lead the world in respiratory infection deaths in congregate living because we don't have things that we're talking about now, like infectious disease training, ventilation, etc. So in the beginning of the pandemic, we started a research project that was a real dialogue with policymakers. And we were able to help make recommendations about which vaccines to use. Moderna provides better protection in older adults than Pfizer, as an example. We were also able to provide real-time data about when to vaccinate people. And although this sounds so intuitive, it was not part of the conversation. Vaccinating people at the beginning of the wave is the most effective time to vaccinate a person because you only get about 3 to 6 months worth of really good protection from your vaccine. So you need to time that vaccination with when you're most likely to get infected. So this real-time dialogue ended up being what influenced when you got your 3rd dose and when you got your 4th dose, and for long-term care, when you got your 5th dose. And so now I want you to turn your eyes to the right side of this graph and see that despite the fact that our older adults living in long-term care have so many risk factors, diseases, medications, frailty, extreme old age, we're now at a point that the timing of these vaccinations and using the right vaccine means that their death rate is lower than older adults living in the community. Long-term care deaths are actually lower than people who are considerably younger living in the community who don't have the benefit of having this really concerted vaccination effort. So this conversation between policymakers and between researchers can lead to really quantifiable changes. And I think vaccine preventable infections and vaccine preventable long-term health issues is something that we can collectively target and advocate for. The Lung Health Foundation is Canada's largest nonprofit. I have to acknowledge I sit on the board of directors, and they are currently developing a national health lung action plan at the federal level to begin to have this conversation and to have real goalposts and guidelines for how we treat lung health. It is incredibly inequitable in this country who has access to spirometry, who has access to respiratory rehabilitation. And by setting these goals, we hope to make a real change in how people are treated for lung disease in Canada. Also, as I said, we have so much work to do in our policy around vaccinations. So easy, and yet we're not using these to our best, to their best use. And of course, access to care. So this is one of the directions that I hope the Firestone will move in, and really being the thought leaders in developing these federal policies. And so what you'll see on the left there is a young person using a Firestone innovation, the aero chamber. And some of these loud and proud voices in advocating for these improvements. So I have done my colleagues a terrible disservice. When I got invited to do this talk, I thought I would be able to do a broad sweeping overview of all the amazing advances we're making in sleep medicine and chronic cough and our lung transplant program, our Rest-Onc program. I also wanted to speak in great detail about all the incredible guideline development that's being done by our colleagues to help move the dial, but I'm afraid there just isn't time, but I promise I'll come back whenever asked. So let's look towards the future as we finish off. Our healthcare system was created in a time where our population structure was fundamentally different, and we had more taxpayers than people who needed chronic health care. And we're now living in a world where our population structure is not distributed that way. We have fewer taxpayers versus retirees in that ratio. We've also, in the past 30 years, moved to a point of incredible income inequality. And this has big impacts in the number of people who suffer from chronic lung disease, also in their access to treatment. We are living in a world where we don't yet understand the impacts of things like vaping and cannabis on the long-term health issues. We've just gone through an incredible RSV wave, and unfortunately that means we can expect an increase in childhood asthma, as there's an association with RSV and the development of wheeze and asthma. We don't yet know what the effects of COVID-19 will be on the lung health of children, but we do know that middle-aged and older adults have decreased productivity and increased healthcare utilization. It's believed that 15% of the labor market shortage is due to the health issues associated with COVID infections. And again, we don't understand what the long-term health effects are. In my short time at McMaster since 2009, I've been around for 3 or 4 different viruses with pandemic potential, and there's no reason to believe there won't be another. But what we'll be entering with is an older population with more income inequality and the health burden that exists from COVID. So what will also be in a more fractured society with less trust in vaccination and many other effects. Although this sounds like a bad news story, I think that we have assembled the team of people who can deal with these future challenges. Respiratory market, but with everyone's concerted efforts, we hope to reduce the burden of disease and improve health outcomes for the people living with it today. So with that, I'll thank you. I hope I have time for 1 or 2 questions.
Thanks, Don. That was excellent. A really tour de force overview of an enormous enterprise. We really appreciate it. There are a couple of questions, but Herzl's asked if he could ask a question verbally. So Herzl, you can unmute yourself if you want to ask a question. We probably only have time for this one question.
Well, that's a lot of pressure. Don, that was a superb, a very nice overview, and I'm very impressed, and I think we all should be, about all the stuff that's happening at Firestone. It's fantastic. Just as you were going through all the comorbidities and all the things that are contributing to lung disease, it's really, I was struck by the absence of probably the commonest disease in older people, which is diabetes and prediabetes. And there is an unstudied, very unstudied relationship between lung disease and diabetes, which is kind of off the radar screen, but I think there could be a real opportunity and potential there to kind of break new ground. Imran and I have discussed this in the past, and I think this is something I just want to just highlight for you, but I think this is superb, and you've got the tools at the Firestone there to really address and push the envelope in these new areas. So thank you.
Thank you. I'd love to do that. I mean, type 2 diabetes is, again, a disease that's associated with chronic inflammation and age, and then has this feed-forward loop in the context of chronic lung disease. And I think you're absolutely right, especially in the context of dissecting both the role of the disease and the role of some of the treatments that are associated with increased risk. That's a beautiful mechanistic question that we'd love to address.
And I'm going to take the liberty of combining 2 of the questions into one, because I think they're indirectly related. So Greg Kernew asks, can you comment whether patients who've had a previous Prevnar 13 should get a Prevnar 20? And then Jerry has asked a related question, which is, do vaccines work only by preventing specific infections, or is there a more general benefit from stimulating the immune response?
Yeah, so I'll give you a great example. So an influenza vaccine decreases your risk of group A strep and bacterial pneumonia. And so one of the things that to survive a viral infection, you often need to turn on a bunch of these immune responses called type 1 interference, et cetera, which ironically suppress your ability to deal with bacterial infections. So one of these weird associations is it's not because there's some magic cross protection, but by reducing the viral burden, you reduce the bacterial burden. Yes, you should get your Prevnar 20. And the reason for that is older adults, the serotypes that tend to infect older adults are better represented in Prevnar 20 than they are in Prevnar 13, which is better suited to kids. So yes, you should still get Prevnar 20.
Excellent. And then what I'll do is I'll invoke chair's privilege. Greg Kernew's asked a bunch of questions, which I think you'll have some specific comments on, but I'll ask Greg maybe to send you an email directly, because he can just copy and paste them. There are some very specific questions in there, but I will ask the one question, which he asked a couple of times, is how effective are HEPA filters from your perspective for COVID-19, particularly the sort of ones that are sitting in the corner of your dentist's office?
Well, actually your dentist is the right person to ask. So their understanding, because of their risk for TB and other infectious disease, is far ahead many other professions. So I think the data is pretty clear that a good HEPA filter, I mean, you know, we are, as a basic scientist, we have worked with the COVID virus itself, and we use HEPA filters and masking to keep us safe. So implementing, if that's good enough for a level 3 lab, then I think that is also good enough for most of us. So I think it is super important. Air circulation is the clean drinking water of the 21st century, I think.
Great response. Thanks very much. And we'll end it there because we are a little bit over time. So Dr. Bowdish, thank you so much for a real tour de force, and thanks everyone for attending. Next week, we will return with our usual grand rounds hosted by Dr. Verhofstadt and Dr. Azam, and thanks to Don for an outstanding presentation, and have a good day, everybody. Bye now.